Hello, everyone. I'm Dr. Jennifer V. Brown, your stroke specialist, and today we're going to discuss stiff knee gait after stroke. When you look at this video, I want you to think about the gait impairments that you see. We're going to look at swing phase first. So, first of all, there's no arm swing. That's a flexion synergy pattern. But when you look at the lower extremity, that's an extensor synergy pattern. He may have these patterns because of contractures at the joint, hypertonicity, and what we may term spasticity, which is velocity dependent stretch to a joint. And there is a reactive muscle movement, but he's walking very slow, and you really don't see any of that reverberation movement of the segments. So you have to assess these things before you can hypothesize why we have the gait impairments. So if you notice at his pelvis, it's not rotating forward, which you need to get a longer stride on the same side with hip flexion. Also, there's no deceleration of the thigh component so that the tibia can move forward on the leg. That should happen at terminal swing. At mid swing, you don't see enough thigh and hip flexion so that the tibia is vertical. Pre-swing, the toes are not balanced on the ground so that you get the foot and plantar flexion with a passive knee flexion. And that should occur right at the end of stance phase. If that did occur, you could then get that active hamstring knee flexion at initial swing. You don't see that either. And at mid swing, the foot is not horizontal to the ground. Let's look at what happens at stance phase. So at stance phase, there's initial contact with the lateral border of the foot. And in loading response, the heel should come down first, even though it's inverted. And then you have this rapid movement into pronation where there's an unlocking of the midfoot and the tibia internally rotates and goes into forward movement, getting that passive knee flexion. You don't see that. And from loading response to mid stance, there should be movement of the pelvis over the knee. That does not occur. That pelvis stays posterior to the knee, and the knee stays posterior to the ankle. From mid stance to terminal stance, you should see a trailing limb in which there is closed chain dorsiflexion. The ankle is posterior to the knee, which is posterior to the hip. That doesn't happen. And we've already discussed from terminal stance to pre-swing, there should be a roll over on the forefoot, and you get a forefoot rocker and a toe foot rocker in which there is passive knee flexion to prepare for initial swing. So these are some of the questions you need to ask regarding the cause of the gait impairments. Are there contractures at any of the joints of the lower extremity? Is there a sensory impairment such as proprioception or body awareness in space? If they can't feel where their body are, they're not going to produce the active movement in order to get the muscles to generate a force to move that segment. Is there hypertonicity in any of the lower extremity muscles and those of the pelvis? The movement you see may be a result of clinical hypertonicity in which there's overactivity of certain descending tracts to get the muscles to become stiff because now they know they're in an upright position and they need the body to stay stable as it is in a vertical position where there's loading on the feet. You have to ask it, are they walking like that because of pain? And where is that pain coming from? Is it a bone pain, a nerve pain, or a muscle pain? And the precursor for gait. Do you have to ask, is there bending at the hip, knee, and ankle during functional activities such as sit to stand or kneeling or during an other functional activities such as stair negotiation or curb negotiation, because if there's bending during those functional movements, there's the potential to bend, and we have to train that bending during gait. Remember, I am your trusted resource for all things stroke neurorehabilitation, and particularly ankle foot orthoses. If you're enjoying these videos and gaining information from them, please share. They come available every Tuesday and Thursday. And don't forget the references. Evidence-based practice will lead to the best clinical outcomes in practice if we appropriately apply the information. Thanks for listening. See you next time. Bye.